This topic has some personal interest for me because I just spent the last year caretaking for two elderly parents. My dad, 92 with diabetes and all kinds of foot issues, neuropathy, and in reading your paper, wow. So this patchwork of coverage across the 50 states and DC is very complicated, which I had no idea. And on top of that, it looks like this is definitely a topic where we're brushing up the health inequities. The people with diabetes and CBD and these other sort of chronic diseases that are managed tend to be in, socioeconomic lower classes, larger proportions of communities of color. So explain to us, some key takeaways here on what you found.
Well, going back on what you said, I also cared for my mom when she went into a nursing home and got podiatry bills we had to pay. I will say Medicare, which obviously if you have a parent that's over 65, Medicare covers these services, blanket coverage. Again, for people that fall into those categories, diabetes, peripheral neuropathy being two of them. So again, that sort of sheds some light onto this inequity between Medicare and Medicaid. But so I guess some takeaways from this. One is, as you mentioned, that I was struck with was just how disparate the sort of regulatory scheme was across different states. My background historically has been in criminal law. If you were interested in that, you went to the state code. It would be in a chapter there, and there would be some case law, but you knew where to find it. It really is just how kind of piecemeal these different programs are administered in terms of where you can find the regulatory documentation. You have one state that it was in a Medicaid provider manual, it said the word podiatry covered. There was a table related to copays, and then it just said covered. So there's one line in one table in one document that is the entire sort of regulatory scheme for podiatric coverage. And then you would have states that it's in 3 statutes and 2 different regulations, and it's all across the board. So that sort of struck me. The other thing that I wasn't prepared to find, or that was interesting, was how states deal with the concept of routine foot care, which would be something like clipping toenails or dealing with calluses and things of that nature. And our research team, when we did the 5-state memo, and then in sort of batches of 10, I had 2 researchers, each would do 5, and we would have weekly meetings. And it really became apparent how differently states handled this, not only from a coverage, not coverage standpoint, but just how they define it, how they define how people are eligible for the services. It really is all across the board. And there are situations, there are states where in one bullet point in a provider manual, it specifically says routine foot care is not covered. And in the very next bullet point, it will say routine foot care is covered if you have these conditions. And if you obviously people who deal with this for a living understand that, and there's the sort of prevailing professional and sort of regulatory information that gets passed out, and people that provide the care understand these contours. But if you are someone who's doing research on a particular topic, or if you're somebody that is looking at these documents for yourself to determine whether coverage exists, it's going to be very difficult for you to sort of pin down exactly what this means.
Without having a crystal ball, Tom, can you sort of give us what your hypotheses might be? Are there going to be some basic routine care things that you would recommend that, may save infinitely more than, say, other kind of services? Or do we go to a policy advocacy position where we just say, come on, this routine preventative care just isn't that expensive. We're talking about clipping toenails and basic hygiene in some cases. What do you think?
Well, you're getting into the clinical realm there a little bit, and any of this I know is from reading articles and trying to pay attention to people that are a lot smarter than me on the team. But in terms of which services I think have more bang for the buck, if you will, yeah, I don't know. That's certainly something that we wouldn't sort of turn a blind eye to if it were in the data. I don't know that we have really thought about trying to get that granular. There have been some really interesting and relatively low cost innovations in the last maybe 10 years that I think, sort of looking at it from the outside, just makes sense. One of the things, like thermal imaging, a relatively inexpensive thermal imaging device that a patient, a beneficiary at home could scan their feet with and look at hot areas of increased blood flow that might indicate my shoe is rubbing here, it's not wearing properly, or because my back hurts, my gait is thrown off, or because I have a diabetic foot ulcer here, now I'm developing one here. So that's a relatively low cost solution. The other thing, and we've gone back and forth on this, talking about routine care, and you hit the nail right on the head when you said routine preventive care. One of the recommendations that we are going to make is to stop calling it routine foot care, because if you refer to something as routine, it sort of puts it in people's minds that it's something anybody can do. And why would we pay for that? Why would I pay for a podiatrist to clip somebody's toenails? I can clip my own toenails. Well, for the reasons that we talked about a couple of minutes ago, not everybody can do that. And so a more accurate description of these services is preventive foot care. And what we would like to do is try to increase public awareness of this, not only for policymakers and legislators and economists and the people that have the sort of gatekeepers on this, but for the public, so that people sort of realize the value in these preventive services if you're in that subpopulation, the same way that we have looked at, mammograms and colorectal screening, immunizations and things of that nature, that these are the preventive things that, if you have an increased sort of risk of breast cancer or colon cancer, you're going to be screened more often. If you have diabetes, you have peripheral neuropathy, that you need to be seen by a podiatrist to perform these types of services. So we want to put that out there sort of in the public consciousness and, raise awareness of this.
One of the things that struck me was when I started to take my dad to his appointments for the diabetic, this sort of what most of us would think as toenail clipping is actually they're using a Dremel tool, right?
Debridement.
Right. And so I think education about these issues for this particular subpopulation, people with diabetes, where a lot of us think, oh, well, that's just not a big deal. It actually is a very big deal. We can improve quality of life for longer periods of time for this population, as well as save healthcare costs long term.
And it really is about preventing that first incidence of a diabetic foot ulcer, a third of which never heal. And the follow-on rate is, I don't have the number just off the top of my head, but the probability that there is going to be a recurrence either of that in that same area or in a different area is very, very high. And it's just devastating. I think I mentioned this already. Medicaid stands alone really in these federal healthcare programs that do not include podiatrists as physicians in the definition of providers that are covered. So Medicare, which is a much larger federal program, TRICARE, the Veterans Administration, the Indian Health Service, they all include podiatric physicians alongside MDs and DOs. And there's actually a bill before Congress. It was introduced, I think in 2018, it was reintroduced in the present Congress, and it's the Helping Ensure Life and Limb Saving Access to Podiatric Physicians Act, the HELP Act, the name of which is actually longer than the real key provision in the statute, which would simply be to include podiatric physicians in the definition of a physician for Medicaid, which would allow them to bill for these medically necessary services. Again, we're not opening this up to anybody that I just don't like to clip my toenails and therefore I'm going to get the government to pay for this. Obviously, Medicare, they do require these comorbid conditions. It is limited to a particular class of beneficiaries, but the HELP Act, the old saying holds true: politics makes strange bedfellows. But this bill was co-sponsored in the House by a Democrat from Denver and a Republican House member from rural Ohio down in Appalachia, that both saw the need for this. And I don't know the backstories in their personal lives, but as you mentioned, a lot of people have an experience in their own personal lives of somebody, grandma, dad, uncle, cousin, neighbor, that had an amputation due to diabetes. And a lot of people really don't understand the connection between those two things and absolutely how devastating it can be. So, advocating to your congressional delegation on behalf of passage of the HELP Act would be a really good place to start. And again, from a public health standpoint, is just trying to reinforce and do research on the preventive aspects of this service. So what we want to do, and we're actually proposing this now, I'm working with a group of vascular surgeons and limb salvage experts. There's a new sort of subspecialty of vascular surgery that deals specifically with these issues, and it's surgeons and podiatrists working together to look at this. And what we want to be able to do is to look at all 50 states would probably be a little bit too expensive when you're talking about getting those Medicaid. But what we want to do is look at one state versus another, and or within a particular state, pre and post, or even Medicaid beneficiaries that avail themselves of these services versus Medicaid beneficiaries that do not. So there are a lot of different ways that we can sort of design these studies to try to get at this more accurately.